Hospital admission demands are climbing, but physical bed capacity has hit a ceiling. To cope, administrators often purchase new medical technologies. But plugging disparate devices into a hospital doesn't fix the bottleneck. It creates fragmented data silos that actually multiply operational complexity. A true smart hospital functions as an intentionally designed ecosystem of interconnected layers, far beyond a simple collection of new hardware. To achieve that, we have to build this digital architecture from the ground up, starting at the base network infrastructure and extending all the way out to decentralized care in the patient's home. Transforming into an interoperable network is the only viable way a health system can scale its capacity without laying a single new brick. We can model this transformation as a 4-tier architectural stack. It begins right here at Layer 1, the digital network foundation. Legacy Wi-Fi infrastructure simply cannot handle the sheer density of modern medical IoT devices. Hospitals require the expansive bandwidth of 5G and Wi-Fi 6 to manage thousands of simultaneous connections without dropping packets. To guarantee ultra-low latency for time-critical, life-saving communications, hospitals rely on edge computing. This processes data locally at the source, ensuring immediate response times for emergency alerts and remote surgical tools. But massive connectivity introduces massive risk. This layer requires a strict zero-trust architecture, meaning every user, device, and connection is verified before it gains access. Techniques like network access control and strict segmentation wall off critical pathways. This specifically protects medical IoT devices, which often run embedded systems that cannot receive traditional software security patches. If a hospital fails to secure this foundational grid, every new connected scanner or wearable monitor becomes a catastrophic cybersecurity vulnerability rather than a clinical asset. Once the network is secure, the stack builds upward to Layer 2, interoperability and data integration. This is where translation happens. Protocols like FHIR, Fast Healthcare Interoperability Resources, and specialized APIs take disparate data formats from hundreds of different device manufacturers and force them into a single unified stream. Operational tools like real-time location systems that track mobile assets or monitor staff locations pipe their data right into this framework. Patient-facing tools like interactive patient systems that handle meal ordering and pain scale assessments at the bedside use the exact same pathways. The ultimate destination for all this unified intelligence is the central electronic patient record. By automatically routing vital signs and operational metrics directly into the patient's record, true interoperability eliminates manual data entry. It removes a massive cognitive burden from clinical staff and permanently destroys the hospital's data silos. With data flowing freely, we reach Layer 3, Smart Facility Operations, which governs the physical building itself. Here, IoT sensors monitor room occupancy in real time to automate temperature control, lighting, and HVAC systems. Predictive AI algorithms analyze power draw and usage statistics to schedule optimized maintenance for highly sensitive medical equipment, preventing unexpected breakdowns. These internal efficiencies trigger a macro consequence. The healthcare sector is responsible for nearly 4.4% of all global carbon emissions. The automated energy management systems in Layer 3 directly slash that environmental footprint by cutting idle power consumption. Digital optimization also extends to the supply chain. Sustainable procurement and digitized inventory management restrict the influx of single-use items and excessive packaging. This candle status becomes an intrinsic byproduct of this infrastructure optimization. The final tier of the stack is Layer 4, decentralized care. This is where the network physically expands beyond the hospital walls. We see this realized through virtual wards, a model that delivers hospital-level treatment and continuous remote monitoring directly inside the patient's home. To be clear, virtual wards are inappropriate for time-sensitive acute emergencies like sepsis, which demand immediate physical intervention. But they are highly effective for postoperative recovery, frailty management, and chronic conditions like COPD. Consider the pilot program at the North East London NHS Foundation Trust. They integrated WizRAN remote monitoring devices placed in residential homes directly into the central Access Rio EPR dashboard using 5G and APIs. This integration yielded a 45% reduction in physical hospital admissions for that cohort. It also saved the trust between 400 and 500 physical bed days. Because clinicians had access to continuous, real-time data, they could detect deteriorating vitals and execute early interventions long before the patient's condition required an emergency room visit. By shifting stable patients into the comfort of their homes, virtual wards safely preserve scarce physical bed availability for the critical patients who actually need them. The architectural progression is sequential. Resilient infrastructure supports interoperability, which then facilitates both smart facility automation and decentralized patient care. The return on investment is multidimensional. Financially, Leicester Hospital saved £635 per virtual admission. Environmentally, they avoided 8 tons of carbon by preventing 219 hospitalizations. Reduced patient travel and ambulance transport compounds these reductions in the overall carbon footprint. Culturally, staff are empowered. Removing the manual administrative burden allows nurses and physicians to focus purely on holistic care delivery. Crucially, achieving this ecosystem does not require a massive all-at-once capital expenditure. It relies on a phased strategic rollout. True digital transformation acts as a self-sustaining cycle of maturity. Each foundational upgrade funds the next, ultimately creating a highly resilient and infinitely scalable standard of care.